Hi, this is Vic Gatto with the Health Storm. Thanks for tuning in. A great guest today, Dr. Tal Rapke. He comes from all the way from Australia, dialing in. He's about 13 hours ahead. He was a practicing physician, internist. Then he moved into pharma and innovation with pharma, and now he has his own startup in the medication space. Great guy. We dig through lots of issues, start with COVID-19, but then talk about medications, the health system, how we could change things in the US and how other countries are different. It's a great show. Please watch. Again, Vic Gatto with the Health Storm. Thanks a lot. Okay, Dr. Rapke, thanks for doing this. Appreciate you being on the Health Storm.
Pleasure. Great to be here.
And you had to get up a little bit early. It's 7 a.m. where you are, 4 p.m. where I am. So we are literally global on this this show now, which is great.
Yeah, it's great.
So, Dr. Rapke, give the audience a little bit about your background. I know you came out of the pharma industry, and now you have your own startup. Gives you some perspective of your background.
Yeah, so I guess my background as a physician, I've kind of had a great opportunity to see healthcare from a number of different perspectives. I started my career, in the field, on the front line, as they call it today. I'm dealing with patients, and I think that was a really awesome entree into the profession, into the healthcare industry as a whole.
What specialty?
I started as an internist, so I'm mainly based in various hospitals, dealing with patients from an emergency to the wards, and seeing sort of diseases from various perspectives. And I think one of the reasons people often ask, why'd you leave, or what caused you to move forward? I think I think personally, I stopped seeing people, and I started seeing patients, and I stopped really seeing individuals who were traumatized by health and were fearful and scared, and the system just made them bed numbers and diseases. And I even had one experience where literally I was exasperated on the phone, like calling, department after department with a very ill woman who had multi-morbid diseases from bleeding ulcer and a broken leg, and no one wanted her because she was such a difficult patient. And she was literally, I was on the phone to probably 10 different specialists saying, please take this woman. And if I was very worried about their part of her body, but didn't really want to worry about her holistically. And so I thought it'd be interesting to sort of try something different, maybe something a little bit more innovative and creative, and utilize those skills in a different way. And so based out of New York, worked for an online syndicator of health content. We actually created probably one of the largest libraries of health content. We were neck and neck with WebMD at the time, but we syndicated our content where they were a destination website. So we had about 5,000 sites. We were about probably the Reuters of the health world, and stayed there for a little while, kind of understanding how consumers and doctors in the early part of the web were accessing health content. Then moved into management consulting, and finally ended up in pharma, where I became the innovation director at Sanofi. And I think, having, my career in pharmaceuticals started as being sort of more in the product side. I became the medical director, and we were sort of very traditional Sanofi, one of the big healthcare or pharmaceutical companies. And then
give people just a sense of the scale of Sanofi, because you say like big pharma, but it's significant scale.
Yes, it's 100,000 employees in pretty much every country around the world. Had the third largest pharmaceutical company by sales. I believe it was probably 20 billion in sales annually. So it was a very large organization, lots of moving parts, a kind of big machine. And in my last years there, I had the opportunity. I sort of had pitched. I kind of became a bit disillusioned with the approach, and thought that we'd really started ignoring the patient. And I started by looking at sort of looking at the way that we ran clinical trials, the way that we got data, and started thinking about how would we do that in the real world with people's smartphones, and start actually seeing what happens, because a lot of our data came from very rigid clinical research, which was done in specific patient populations, and thought that what if we rethought that and saw how people actually react to our medications and our solutions in real time in the real world. What could that do? And it was partly defensive, but partly also offensive in terms of where the opportunity for the industry was. And
we can dig into that in a little bit later, but I'm really interested in that. I'm calling it real world trials. We're using like the day-to-day interactions with the healthcare system as the data inputs to see what's going on out there.
Yeah, pretty much. I mean, I think there was one of Sanofi's largest selling drugs, which was an insulin called Lantus. There was some, research done on it where they took some databases, and looked at them and saw that there was a signal that came up around cancer, and essentially slashed sales of that overnight. 30% of patients using insulin to stay alive stopped taking them and got very, very ill. And it was a huge, huge issue. And it took us about 2 years to kind of come back from that and create our own data to actually prove that it wasn't an issue.
Yeah, it was a
just
scare, but it was not a real issue. Yeah.
Yeah, but the impact it had on people's lives, the impact it had on sales as well was really unfortunate. And we didn't want that to happen again. And so we started thinking through, how do we get proactive with the people and the data that's happening, so that if anyone comes up with a piece of crappy data, which it was, we'd be able to come back with something even stronger. And so sort of, needing to fortify your own data and get in advance of other people knowing your product better than you did.
Right.
That was kind of where it started. And I think that as a process led us to the patient. Interestingly, there's only 2 countries on earth that are allowed to advertise pharmaceuticals to patients. It's the US and New Zealand. Every other country on earth prohibits that. And most countries don't really have any access to that consumer to know what their experience of it's like. And so moving into that space, I kind of moved into this innovation role, which I kind of crafted, thinking about what the future of healthcare would look like and how do we create a new system that's really consumer centered. And that's where I came up with, that's sort of where I became passionate about innovation, about becoming my own entrepreneur with my own company.
Yeah. So talk about your company, Scalamed. What it is first, and then what did you see at Sanofi that made you think, like, I really need to leave and just solve this problem?
Yeah. So Scalamed is a solution that is essentially smart prescriptions. So we're a company that believes that when we want to solve the issue for medication mismanagement, if you actually look at what happens when people are prescribed medicines, we think and we hope that they're going to help people. But there's $500 billion, 528 billion to be exact, issue where the downstream costs of not getting medications right drive a lot of costs, preventable costs, unfortunately, in our healthcare system. And we're not talking just adherence, because that's about 20 to 30% of that cost. The other costs are, let's say you have a disease like diabetes, you're undertreating it. Well, all the implications of undertreating it mean that you end up having an amputation or some serious consequences down the track.
Yeah.
Or overtreating it, giving someone too much of a medicine, sends them to hospital, gives them side effects that then need to be managed appropriately.
Yeah. There's also interactions. I feel like there's interactions between it. Yeah.
Absolutely. Giving someone a medicine that interacts with another one throws them into hospital, or giving them a treatment and then they're not managing it appropriately and they end up back in hospital is a huge cause of that. So they're all preventable, which is just horrendous. It's about 16% of all healthcare costs when you really dig in. There's a recent paper I can forward people if you're interested. So we're going to solve that. And when we look at all the solutions today, they tend to be quite point solutions. They tend to focus on part of the problem. So, hey, it's true. Cost is a huge issue. So there are some wonderful companies out there doing really cool things about bringing visibility to costs and helping people understand and reducing costs, because we know that if we can reduce costs, people are more likely to take their meds. There are great companies doing adherence and reminders, because that's also important. There are people who are about information and knowledge and content. There are those who are about interaction warnings. There are those who are about putting content on doctors' systems, etc. There are all these various approaches to solving this. And we thought, how do we do this for once and for all? How do we actually rethink that process? And when we looked at it, and I guess having been in pharma world as well, realized that actually every prescription problem starts with the actual prescription. And if you think about what
the doc has to write the script, right?
Yeah, of course. And so exactly. And so what is a prescription and how did it start, right? So it's this idea of, in the past we used to get a piece of paper, and it was kind of cool because we were in charge. We got the piece of paper. We could then had that license to procure our medicine, but it was just a dumb sheet of paper. It could be forged. It could be lost. It could be, you'd have to take it to the pharmacy once and then go back later with the stock. It was difficult. So we came up with a system in the US to digitize those, right? But rather than giving that digitized prescription to the patient, we said, well, why don't we send it on your behalf and ask the doctor to take on the responsibility of sending that prescription for you to the pharmacy? And so we now ask doctors to find your pharmacy, make sure it's open, make sure the price is right, make sure they've got the stock, make sure it's on your insurance, make sure that pharmacy's in network, make sure you're still in that location, and put all that work on the doctor, and then the patient doesn't have to do anything. And then we
don't pay the provider for any of those services.
And we also don't, we don't pay the provider for that. So it becomes a huge amount of workflow. And when a patient, irate patients, we all are, when we arrive at our pharmacy and the prescription isn't there because it was accidentally sent to your other pharmacy or to the wrong Walgreens on Main Street, we get, it interrupts the workflow of the provider and the practice. And it becomes a point where me as a patient leaves a doctor being told I've been prescribed 3 drugs. Maybe I was told the names, maybe not. I'm not sure what they're for and how to use them. I then go to a pharmacy. I'm not sure what the cost is. It's actually the only example of a product that we have to pre-decide where it's sent before we even know what it is. Mm-hmm. And so we thought, what if we took that prescription, rather than having it as a dumb, object that's sent on our behalf, what if we sent that prescription to the patient, laid all of these smart tools over the top of it, and allowed them to really take control over that and empower them with that knowledge. And that's essentially what ScalaMed does. It enables doctors to send a prescription directly to your phone. We lay smarts on top of it, make it smart. We lay pricing. So where's the cheapest place? Are there other alternatives? Is it better to pay cash or pay your insurance price? Yeah. We lay your education so you understand how to take it safely and effectively and what's it for, whether or not you even need it. We tell you, we show you the interactions, the potential issues you may have if you take that. So we really help support the patient. And then within a couple of clicks, you can send it to any pharmacy in the US for pickup or for delivery, including your mail order.
So what I really like about it is the combination of you're sort of simultaneously solving a big problem for the doctor, making the physician's workflow more efficient. It kind of takes a bunch of work away from them that they don't get paid for. And simultaneously, you're empowering the consumer to sort of take their own control, be educated, send it to whatever pharmacy they want to use. And so you're solving a very elegant way of solving for both sides of the equation at once, kind of.
Yeah, look, I think my advice always when I see entrepreneurs and people doing stuff in healthcare, and I think this is some of the things that I learned having been in that innovation space, is unless you really hit that quadruple aim of health, unless you can really get into all those parts of the problem, reducing cost, improving the workflow, getting better outcomes, unless you're thinking about all the players and how they all work within a solution, healthcare is very confusing. No, I don't feel like maybe confusing is the right one, but everyone has their own patch, and you need to really think about, your solution has to help everyone. And so I think that's what we've tried to do with this. And we keep trying to sort of hit as many of the levers as possible, so that it's part of a solution. It's not part of the problem of health.
Yeah. I think that's right. I mean, I talk about the value systems and value networks. It's very intertwined, right? Like if you give a solution to the patients only, but it makes the doc's world much harder, no doc's going to want to do it, right?
No.
And so you have to think through it all. It's complicated, but then if you get the right solution, and particularly like ScalaMed, you sort of make it in an elegant way that solves everything simultaneously, I think you can really help a lot of people.
Yeah, no, thanks. I agree. I think that's a really important approach. I mean, the other thing I'll add just on ScalaMed before I hand over to your next question is that, we don't leave it just at giving the patient those smarts. We then also layer what we call a virtual care coordinator over the top. And so what we do in real time is actually observe how patients going with their meds. Are they feeling them? Are they getting meds that interact with other meds? Are they answering questions telling us they've got side effects through our chatbots and various things that we roll out to them based on their medications? And if we find that they're having trouble, or if we find that they're actually not doing the right thing by their meds, we can then actually identify risk and refer those patients back into their providers or back to their payers, whoever's really responsible for their ultimate health outcomes. And so it becomes quite a holistic and scalable way to support patients in real time with their health.
Yeah. I mean, when you have all that data there, instead of there being a library somewhere saying these 2 drugs might interact and hoping my doc can keep up with that, it's just sort of in real time can be monitoring that and say, you may not want to fill this because it could conflict with another med that we know you're taking.
Totally. And look, and the reality is we just know that doctors aren't working off a full EMR. They're not working off all of your full data. And we also know that doctors in their 15 minutes with you have got to do a lot of work, a lot of, preventative work. They've got to see a lot of the pop-ups and warnings that are coming through their screen, managing a huge amount of moving pieces. And so we're not there to take away that work, but we're there to put in another backstop, another preventative measure, because we know that when a pop-up comes up on your phone that says, hey, Vic, watch out, you're much more likely to react to that and then go have a chat with your pharmacist or your doctor and say, hey, I just got this thing, just trying to work this out. Then all of those warnings that we call pop-up fatigue for a physician.
Right. Yeah. Good. Well, so as you mentioned in the early, it's kind of a unprecedented time with COVID-19 circling the globe. You're in Australia. I feel like Australia is a couple weeks ahead of the United States. So tell me, how is COVID-19 there? What's it like? Is it right for me to say that it peaked? My impression is it peaked a couple weeks ago. That may or may not be right. What are you seeing on the ground in Sydney?
Yeah, so I mean, Sydney's, like many parts of the world, is still in isolation and for the most part an element of lockdown. I mean, people are able to walk and do exercise and do their shopping, but for the most part, most things are closed and everything's moved online and remote, including schools and and the workforce. I think there's definitely a lot of fear, but but there's also relatively few cases in our entire country. So it's a country of 25 million. We've got 5,000 cases, and it's dropping significantly. So bell curve wise, it's on the tail end of that. The problem, I think, though, in general, is I don't think that we're being told the truth about COVID-19 by our leaders. And I know that as a conspiracy theory, but more as this is not a sprint. This is a marathon. We are not going back to the way the world was anytime soon until we have a very effective treatment, or in the next 18 to 24 months until we have, some form of excellent vaccine, which I think is still quite a distance away, or until we have so many tests available that we can test ourselves daily, so that we know when we've got it in that sort of early incubation or early period.
The social distancing and all the things that were put in place by various government entities, they push the infections out into the future, which maybe presented a surge at our health system. So you didn't run out of beds and ventilators, but those people they don't have immunity. Yeah, I don't have immunity. So it's going to just be a delayed process. I think you're right. It's going to be several quarters to several years that we are interacting with this. And yet the economy cannot stay completely shut down for that length of time. So we need to figure out some solution.
Totally. Look, the flattening of the curve is exactly that. It doesn't actually change the area under the curve. So the infection rate will always be the same. I think it does a couple of things to your point. Like it defers, hopefully, it enables us to get ready for it, which we should have been maybe a bit more ready, some would argue.
Yeah.
It enables us to find maybe some better treatments and data to work out who's going to be at risk and who's not. But it doesn't ultimately do that. So I think what we're going to see is a loosening, but I think we're going to see a loosening around the patients who are at low risk. So we're going to see an ageist society for a little while, which is, it is what it is, unfortunately. But we're going to see younger people being able to enjoy life. We're going to see, immunity passports. We're going to see people able to kind of re-engage in various different ways. But I think it's going to be this is a marathon. It's not a sprint. And so, yeah, we're seeing some very
interesting. I haven't heard that phrase before, an immunity passport. That's really interesting. What do you mean by that?
So it's actually something we're actually doing as a little side project at ScalaMed to try and help out. One of the things that, we're kind of bullish on is that, at the moment we have a one-size-fits-all approach to our population, right? So we say whether you're 96 in a nursing home or whether you're, a 15-year-old or a 10-year-old child, you're pretty much stuck indoors. You're socially isolated. But when people have had the virus, like my cousins and various friends across the US, they've actually recovered from it. Even though there's still a little bit of murkiness around what exact antibodies we need to be testing for to prove that, I'd bet my hat on it that these guys are now completely immune and will not get the virus, at least for this particular season.
Yeah.
And so those people can actually go and visit elderly people in a nursing home and support them and visit them and give them company. They can be delivering Meals on Wheels to people who are unfortunate and helping them in their homes. They can be doctors and without PPE because they're essentially immune, saving that important PPE for our frontline workers who don't have that immunity. And so,
yeah, so you could almost
really,
have like a passport or something that was clearly shown that says, I have immunity in this, so I don't have it, and I'm not contagious. And then you can do various jobs that are needed in society for this.
Exactly. So we're pretty bullish on that as an approach for societies and for countries to employ and deploy as soon as possible. I think it just gives people a lot more surety. It means you can jump on an airplane and you're not going to infect the staff working on those planes. I don't know that it means you're going to jump on a cruise ship, because I'm not sure anyone's going to be on a cruise ship anytime soon. But yeah. So that's one approach as well to help our workforce and help our society get back on its feet.
Yeah. Okay. Excellent. Well, so as you know, this is called the health storm. I called it the health storm around Thanksgiving time, which turned out to be very different meaning than I thought. But I was anticipating pretty dramatic change coming to the health systems. Mostly in the U.S., but across the world too, in the next 3 to 5 years, with many trends sort of coming together in the next several years. And then, of course, everything changed in the last 60 days with COVID-19. I see that as accelerating these trend lines. Kind of once we get through the crisis, there'll be a recovery and then kind of a new normal. I don't think we'll go back to the same life and health system we had previously. And so the ideas that I was thinking about, I think still are in play. They just now are changed a little bit due to the outbreak. So the rise of the consumer is one of the trends that actually Scalamed sort of fits with, where people are wanting to take control over their own prescriptions, their own diagnosis, their own healthcare, from a decision-making and directory point of view, but also cost and where they're going to get the care. That's one of the trends that I think is driving things. Another is care moving out of the hospital and into the neighborhood or the home. It used to be that pretty much all care was done in the four walls of the hospital, and that's with technology that's changing. You can do it more convenient, less expensive in the home. I think there's new market entry where big players that are not traditionally in healthcare are moving into healthcare now, because there's a lot of opportunity to deliver better service at a lower price. And then the last is using technology, telemedicine, data science, other tools to really help people. Scalamed maybe is another example of that too. So these things have been going on in the background for a couple of years, but I think that COVID-19 is going to accelerate them. Give me your comments on that storm, and is the storm here? And do you think these are going to be trends that happen, or do you see other things out there?
Yeah, look, I mean, I think a lot of it's going to depend on how long this particular storm lasts for. But I think, you're right. I think all of the factors pushing us towards a new future have, been accelerated. So yes, digital is clearly here to stay. Once you have the opportunity to see a doctor sitting in your home without having to pay for parking, without having to navigate your way through a hospital and sit there waiting patiently as a patient, right. You can do that in your own home. I think the idea that you can go back to that world is gone.
Yeah, and for the doctors too. I mean, they now are getting used to, and I was talking to a cardiologist buddy of mine last weekend. He just on his iPad now just clicks next patient, and he gets paid for it. That's another thing that got changed through this pandemic. That's been good. Yeah.
Yeah, I mean, I think the deinstitutionalization is clearly here, and I think that's going to be something that's going to be big. I also think the idea that healthcare used to be tied to geography is going to also be a little bit, with as things move digital, the idea that your doctor and healthcare system is, must be the regional one that you're forced to stick with because it has such a monopoly in your place becomes a little bit dated. So you're going to be able to be sitting in Louisiana and seeing a doctor who sits in Iowa, and you're going to be able to get care more effortlessly, the right care for you, depending on where it exists.
Do you think that's true globally too? I mean, every other industry is global. I mean, I don't see why health should be any different. Pharma's already global.
Yeah, absolutely. I mean, I think we're starting to see examples of that. But I think, if you're a doctor and you can see patients anywhere in the world, might there be a bidding war as well around that? So might we start seeing sort of bifurcation of costs where you have sort of, the famous and well-known doctors charging more, and it becomes less, maybe we move away from, hey, I want to go to Mayo, but I actually want to go to Dr. X at wherever the hell they are because they're an excellent doctor. And might that workforce be able to be, exported globally and be able to see that? I mean, I know I've had the experience of unfortunately having to manage someone who had cancer and needing to reach out. And, I with my background was able to sort of reach out to some of the best oncologists across the globe who are all very, very happy to, offer advice remotely. So I think we're going to see a little bit more of that as well. I think, mental health is going to be a really interesting space post this. I think that maybe it's an immediate thing, but I think, as we digitize, we also get increased loneliness. We have increased mental health issues. That's going to, drive things in a very interesting way.
The social isolation, it's in the name, right? The isolation is really hard on behavioral health factors. And then it's high anxiety times. I mean, it's scary times. There's a lot of uncertainty. I think it accentuates behavioral health issues pretty dramatically.
Yeah, no, I fully agree, and I think there's going to be, I think the other questions that I think this COVID raises for us about the future is, we're sort of seeing this kind of idea of the frontline staff of hospitals being, seen as heroes, and one of the questions are they going to be seen as heroes to the point where they're going to be untouchable? The idea that you could touch the healthcare system and try and reduce costs and push that through the system, is that going to become one of those, these guys are like, post-World War, like our fighter pilots, like those guys, the heroes that you can't really touch post this crisis? What are we going to see happen to private insurance? What are we going to see when we have 20 to 30% unemployment? I mean, that 20, 30% of people are not going to have any healthcare cover. And so are we going to move to more of a universality of healthcare in the US, which is long overdue? So I think there's going to be some really interesting, big changes in this space that I'm really excited about, because I think we was due for a disruption. I think we needed something like this to help us see the folly of our ways.
Yeah, so that's one of the things I wanted to talk to you about is the timing of things. So, timing in healthcare is always really the most critical thing. As an investor or as an entrepreneur, we need to think about not only what is the right solution for this market opportunity, but when is it going to be adopted? Like Scalamed 10 years ago probably would have been too early. Now it's the right time. Same on the investing side. I've lost plenty of money being right, but 5 years too early. And so you need to be right and on time. Totally. And so talk to me about how you see this. We're in crisis now, certainly. I've been talking about the recovery and new normal. And I think it's really tied to more factors that are not date-driven, but more activity-driven, right? So we have a test that's widely adopted. We start opening up half of the economy, let's say. We do elective procedures, and we can see, we can go to clinic. Talk to me about how you see the recovery phase and then the new normal. What does that look like?
Yeah, I think at the end, it's hard to know exactly. If you're talking about it from a healthcare perspective, I think the three big things that are going to be part of our recovery phase are going to be a much stronger drive towards value-based healthcare. So I think this idea of we've reduced cost on a lot of these, interventions like telemedicine, for example. I think we're going to see a much bigger drive towards outcome-based healthcare, and we're going to see a demand for that as people sort of move into Medicaid and Medicare and other kind of government-based solutions. So I think we're going to see, drive towards outcomes. We're going to see a greater digitization, and we're going to see patients who are now empowered because they've been forced to become empowered and forced to become digitally native. And I think we're no longer going to have excuses by groups and providers that patients don't have data, or they don't have phone, or they don't know how to do it, or digitally managing patients is not there. And I think this is going to really have a big drive towards focusing the spend in the right places and making sure that we're not spending in things that aren't necessary. I think you're seeing today healthcare systems laying off workers. So I think we're going to see people are going to realize that we need to be a lot more frugal when it comes to healthcare, be a lot smarter in how we deploy that. So in terms of how that's all going to come on board, I think we're seeing workforces in healthcare that are being decimated. So people are being discharged. We're seeing a repurposing of workforce. So we're actually seeing air hostesses now being asked to go and coach people and do some of the early triage because they're really good customer people that they can speak to people, they can triage them, they can get information off them in a very calming way. That's how they're trained. So we're seeing a really interesting thing around workforce, about remote workforces as well. So I think, there's going to be some real interesting changes around how our health force engages people. I think the days of the institution are done. I think people never want to go into a hospital. I mean, I don't know if you've been to one recently, but they're horrible places. Like they're just not a good place for healthcare. They were built in the 1900s when we didn't have any data or knowledge or weren't able to manage our health alone. But in a system where 80% of healthcare is chronic, it makes no sense to have that managed in an institution.
Right.
I don't know if that answers your question, but I guess, there's a lot of sort of...
Yeah, that's helpful. I mean, it's maybe an unfair question because we're still in the middle of the crisis, and be able to predict it is challenging. But I think that those are all things to pay attention to and watch, certainly. Talk to me about the health systems themselves. I mean, certainly care is moving out of the hospital. You just mentioned yourself, they're designed really for trauma or for procedures where you fix an intervention and you fix the patient and send them back. They're not really designed for chronic care. And so do you see health systems as kind of wearing a bullseye for change and they're going to be very different? Or do you see them as always the center of the health ecosystem? And yes, we'll add around the edges of it, but there's always the centerpiece there.
Yeah, look, I mean, I don't know of any people would have said the same thing about banks, right? That the central point of your financial world would have been the bank. You go in there, it's the teller, it's the banking manager, it's all that stuff that you go in there in person and have that dealt with. I'm not sure that anyone would really believe that the bank is part of that. I think that the bank is a center of their financial universe. I guess it's a tool to help you manage that, like many of the other tools that we have. So I do believe that deinstitutionalization is coming our way. I think provider groups and systems need to change. And I think at the end of the day, the central point in any system has to be the consumer. And any industry on earth that has not put that consumer smack bang in the center of their journey, empower them with knowledge, data, support, technology to make their journey easier, make it intuitive, and then offer support on the sidelines when you get stuck or when you need interventions. I think any industry on earth, I can't think of one, they fail. So I think, we're just
I think healthcare was designed really with the physician at the center.
Totally.
And that made sense in the 60s, 70s, maybe 80s. And then as we're shifting now, that we have to shift. And that's going to be painful transition, but just some institutions will do it and will then grow quickly. And the physicians will be critically valuable, but they're not the centerpiece. And other ones will have a hard time changing. That's just sort of the normal life cycle of a business.
Yeah, I mean, I still kind of cringe in embarrassment at, having gone through medical school. I was led to believe, and I was taught an arrogance that I don't naturally have around my title, being doctor, and around who I was when I walked into hospital. I walked in there on first day post medical school, being like, "Hey, welcome, Dr. Rapke here. Okay, what do I do now?" But I literally was taught this arrogance of who I was, and I think
where the poor nurses and med techs are there every day doing stuff and have a lot of value, but they don't have that title. They don't have that.
Totally. I mean, I walked in there thinking, being really dismissive of nurses and the value that they play. I was just taught badly, and I think the entire system was taught badly around where the role of the consumer is and how do we think about healthcare. And the fact that we still go to doctors and sit there waiting for 1 to 2 hours drives me. It's an arrogance that is unprecedented. You go anywhere else, into a lawyer, any other profession, they'll call you, say, "We're so sorry, we'll let you know when we're running." But the arrogance of saying that you need to wait because you're the patient is something that I just think it really is a signature of healthcare. compared to anything else. And I think we really need to change. And we've always thrown this kind of X factor into healthcare, saying, well, blah, 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 but it's about your health. And you can, as if you can pull this rabbit out of your hat and use it as an excuse. The reality is that, even the work of hospitals, we always, we knew this as physicians, that we barely treated patients. We just tried to keep patients stable so their bodies could do their own healing and get them to the point where they heal themselves and get out of hospital. And that's really a lot of healthcare. It's, most hospital systems and management is about stabilizing a patient so that they can heal themselves. And sure, there are tools of the trade and meds and procedures and various things, but I think we're going to see surgery decreasing over time as better medicines come our way to manage diseases that were either previously needed surgical interventions. We're going to see, and a lot of those medicines don't require you to be in hospital anymore. The fact that, you don't need to go to hospital and have infusions for cancer, you can have those in your home. So I think there's going to be a big change. And I think there's a lot of resistance to that because, we're a very strong workforce, the doctors, where we're going to become a little bit untouchable post-COVID, unfortunately, so that there's going to be a little bit of we still must bow. But I think that will evolve, and hopefully we're going to have really smart leadership that will see this opportunity, and consumers are going to demand it regardless.
Yeah, I think that's right. There is probably a process of kind of respecting all the work in these scary times that doctors and nurses and all the healthcare workers on the front lines have done.
Absolutely. Absolutely. Amazing work.
At the end of the day, we have to evolve the system because this pandemic is costing the globe trillions of dollars, and we're going to have to recover that and not waste money in healthcare. There's plenty to do about being efficiently spending than be wasteful. So.
Yeah, and I think it also, I agree. And I think, it does also raise the questions of, of the construct of healthcare in the US around, federal versus states, who's paying, who's not. I mean, the fact that people could go bankrupt from getting COVID-19 and lose their homes is just devastating.
Yeah. It's devastating, and nowhere else on the planet is that.
Nowhere else on the planet. And that people can't afford their medicines. And we see this all the time, that people come to us saying, I can't afford what I've just been prescribed, help me. It's devastating. People need to share their insulin. So we really think there is a different way, and it's going to be painful for the US healthcare system. It really will. But at the end of the day, the people that will win will be the ultimate, will be you and I, will be the patients who, at the end of the day is what we're here to do. We're here to make people's lives better and easier. And I think if we can do that more cost effectively, we'll also put a lot more money into people's pockets. I mean, the fact that 18% of every salary, really, because it's 18% of GDP, goes towards healthcare is too much.
Yeah, right. Yeah, so talk to me about public health, because I think one of the things I've taken from this event is that we need to invest much more in public health. And I think the U.S. broadly underinvests in public health. When we invest a ton of money, we spend a ton of money. I don't know if we invest it. We spend a ton of money on healthcare. We don't really spend as much as other countries in public health, education, food, exercise, children. And I think that's going to be a significant change in the next few years. What are your thoughts about that?
Yeah, I mean, absolutely. I mean, we have to meet people where their healthcare needs are. I think what's going to be interesting is, I always sort of say, when you've got sort of two governments, like, Republicans and Democrats, I think, Democrats are always going to be pushing for that. But I think, with the Republicans being forced to become quasi-Democrats in this particular, arena of, you have no choice but to print money and give people money where you would have found that abhorrent, give people healthcare where you would never have done that in the past. I think Trump has an opportunity, or the Republicans have an opportunity, to really seize the day, to actually destroy the Democratic platform about healthcare and Obamacare and actually own it themselves and realize that there's got to be a better way. So I think if you're asking about what's going to happen in this healthcare environment and how we're going to sort of get the public purse spending on the right things, I think there's going to be a big change. I just fear that that's going to fall into protectionism and nationalism, which I think is the wrong approach. I do think, just in time, supply chains, yes, need to be rethought, but I think the idea that you should just move towards just close down global markets is probably not a good long-term strategy. But I do think that the idea that we are proactive in public health, that we realize that, when people are going when people who are uninsured and are, indigent and not part of our healthcare system are falling through the gaps, end up in hospital and bankrupts them, it actually destroys value from society for everyone. And I think, I think that's, I don't know, maybe it's my, I don't want to make this political, because I think healthcare is something that people just should have the right to have good health and be supported when they're not in good health. So yeah, I think there's going to be a lot more spent in this regard. And I think,
whether you go to an entire public system or stay in sort of the public-private partnership that the U.S. has now. I mean, the truth is the U.S. today, 50% of the market is paid for by the federal government. So, we already spend a lot of money out of the government coffers to healthcare. It's branded differently, but I think that's immaterial. The point is, I think we need to invest in public health. We need to invest in vaccines, in education, in disease tracking, but also in diet and food and exercise and teaching people how to manage their chronic disease and try to get more preventative efforts going, because it's the right thing to do, and it will benefit. How you pay for it is different than just the fact that we need to have it.
And I think the saddest thing about healthcare is it's now becoming a socioeconomic issue as well, right? So we're finding
seeing
people
that in the fatality rates, certainly.
Absolutely, yeah, and the fatality rates, but also just across the board. Like, we know that people who are less wealthy do worse by their health, and it starts with, you're right, it starts with education, starts with the schooling system. And there really is a lot of things that drive that. There's you can't afford good. It's expensive to eat beautiful salads and healthy food, and understand that it's when you're not given good food at school and at home. Like, I think it starts very young. And we also know the social determinants of health are huge. So I think there's a lot more understanding now than there was previously, and how we evolve and how we look after our more susceptible people in our society. I think reflects on us as a society. Like, are we good? When we're good to those people, I think we can stand with a straight back. When we see, when I go to San Francisco and see what's happening on the streets, and then you think about the wealth that exists there, it's shameful. And so I think there are things that we can do better as a society.
Yeah, there's no question about that. I want to come back to the clinical trials work that you were looking into, because I'm really interested in the kind of expanding the normal kind of CRO clinical trials process and getting more trials, and just utilize the data that, I go to the doctor twice a year. I have other things done. If something happened, I'd be in there all the time. There's lots of data that's generated at physicians' clinics and in hospitals all the time. And to overlay sort of clinical trials on that, it's obviously more complicated, but that is much more effective, and you get a much more diverse population than the populations that are in the CRO platforms now are usually the wealthier, a lot of Caucasian folks that sort of can opt in for that. Talk to me about your studies there, what you looked at with that.
Yeah, look. I think I can't necessarily see us moving away from the double-blinded clinical.
Gold I think it's both ends. Like, I'm not saying we don't do the traditional.
But I think what happens in the real world is often is kind of we see data in clinical studies that just don't play out in the real world. And so I think there's always been this question of why not, and so the idea that people can be informing us in real time of what's going on, and we can pick up signals is just really critical. I mean, if you think about just drug development, right? So you give a drug to 1,000, 10,000, 100,000 people in a massive study in a clinical development, and that's great. But what if it's 1 in 100,001 patients gets a particular side effect that is so devastating that it's unacceptable? Right. Or we realize, because you start giving out to larger patient populations that are doing things. So let's say when you mix it with tomatoes, it does something terrible to your system. Right. Our inability to understand how that works and prevent that or get on top of that is a challenge. So I think you're right. This idea that, the data that you have on your phone that you're reporting back on a continuous basis, the data that exists in many people's systems can be leveraged, I think is a huge opportunity. it's also a very complex one, right? Because, the data sits everywhere. But I do believe that as we start recognizing that data doesn't belong to the hospital, it doesn't belong to your doctor, it actually belongs to you. Mm-hmm. And that you have the right to be able to share that with whoever you want. You actually have the right to access it. And now with recent HHS, CMS rulings, you can actually the hospital systems are actually going to be penalized if you don't get access to your data and get full ownership over it. We're going to see a very different mobility of data that we've never seen before. And I think that creates a lot of opportunity around how do we leverage this data for good to help support people and actually to utilize that data in research and in research. So how it's done is going to be, people who are way wiser than I, but I think there's definitely some real opportunity in that space.
Yeah. I mean, I think the approve this drug or not, safety, efficacy process, there'll be a mix. You're always going to need the double-blind CRO, very controlled, tightly controlled study. But I think there is like you're saying, broader for 1 in 200,000 side effect things or particular food interactions. I think there's also a need over time for kind of a value assessment. I mean, some of these drugs are pretty costly, and are you getting incremental value for the incremental cost? Sometimes you need a lot of data over many, many years to really make that assessment. And I'm not begrudging the pharmaceutical companies. I mean, some of them do deliver value, and you should pay for it because it's delivering the change. Others aren't. And once we know that, then we can change the reimbursement structures.
Totally. I mean, look, reimbursement should be something that becomes more like you can imagine becoming more like a SaaS model, right? Where, we're doing some really interesting work on a drug that works more like a vaccine actually in multiple sclerosis. And it was the early days of the clinical research. And we saw that if you gave it to someone, we actually didn't know how long it lasted for. And so we would argue with these, with the value-based payers, which was the great discussions around, well, are we giving this drug to someone, you give it one time or 2 or 3 injections, and then the drug lasts for 2 years, 3 or 4 or 5 years. So the value depends on how long it lasts for. But if it doesn't work, should anyone have paid a cent for it? And so clearly every drug has its patients that it doesn't work in. And so it's really interesting when you start thinking about that and thinking about the value that it brings. So this is a drug that, if it lasts you for 5 years, you should be paying someone should be paying, the people who've, come up with that innovation over time, the value of what it means to keep someone healthy and working and without symptoms for 5 years versus giving someone a drug that doesn't work, where really they shouldn't be paid at all and maybe should even be penalized for that. And so I think when you start tying reimbursement to outcomes, which is really where healthcare needs to be, we start becoming really smart and it becomes really interesting. And then the
incentives line up, right? Like all the biochemists decide, well, we need to figure out how we can squeeze another year out of this because we'll get paid, another 12 months of our SaaS payment.
And the patient then gets incentivized for reporting back on how it's going. So the patient's like, so it becomes a really interesting space. And I think, we always knew that, as well for, as pharma, the more data we can prove back to doctors of what's actually happening to that patient. Because if you're a physician, you're seeing you've got a caseload of 2,000 patients. You're seeing a patient once, twice a year. You don't really know what happens in between. So when they come back in, they're going to report back to you and on what's going on. When those patients come back and tell you that they're doing really well and they're well managed and their side effects are not there, you're more likely to prescribe that drug again. It becomes like kind of this virtuous cycle of the better we can do and the better data we can feed back. And it's a really interesting space. It's a space that's been ignored, but I think is really, really, really wide open at the moment as data and technology becomes, ubiquitous.
Yeah. Good. So you've been working on this for, 15, 20 years, various different parts of management consulting, pharma, now innovation. What do you wish you knew when you started that you know now?
That's a great question. So I think there's probably 2 things that I wish I'd known. I think one thing I wish I'd known is that sometimes that, crises pass and what seems really, really big and impossible to get over at the moment becomes a faint blur in the distance. So I think just from a sort of Zen perspective, just observing and being equanimous with what goes on, there's good, there's bad, not to get too attached to it all, I think that's a really important lesson that I've learned over time, to try and keep an even-headed about things, because, celebrate your effort, don't celebrate the outcomes, because sometimes those are things we can't control. So that's kind of one I wish I'd known a little bit further back.
That's a good one for all of us to just remind ourselves in these times. I mean, I'm going to go downstairs and turn on the news, and I just need to not turn on the news some days, because it's not that fun, and they're all like crises all the time.
Yeah, the other thing that I think I'd wish I'd learned is just to be a bit more present. I know these are maybe not healthcare things, but they're, there's so many distractions. There's so many other places we can be, but the most important place is right here, right now. And so, if I was on my phone and trying to do 10 different things and talking to you, we wouldn't have had a great conversation. And so I think just learning how to sort of be here and not wanting to be anywhere else. And I think this COVID thing's actually been a really good lesson in that, being at home with the family and having this really awesome time to spend with my kids, and trying to be really present and very, very local, but at the same time, very, being able to access the world digitally is really an interesting experience. So I think, yes, being present with whatever problem they had, giving people time, I think is just really important. So as a manager and as a people leader, giving them the space that they need to be able to talk, to be able to tell you what's going on. Just being present for people, I think, is something that I wish I'd had more of, both as a physician, both as, in the workplace. I think it's just really important. I think time is one of those things that, is our one commodity that we don't have limitless, enough of. And I think we hopefully learn to, where do we put our time so it's most effective? And I think that's a really important thing. And I think the only other thing I'll say, sort of from a healthcare perspective, is I think the lesson that I did learn is that, you do need to be really thoughtful around all the various parts of healthcare and how it all the jigsaw pieces fit together. Because as much as we'd love a utopian world where the best outcomes and what the patient wants they get, and just solving a problem for one part of the system and that working, it's just not how it works today. We have a very intertwined system with payers and plans and PBMs and patients and government, and that's the system we have. And there are good parts to it and there are bad parts to it, but it is what we've got today. And I think we have to work with what we've got. We can dream about a new system, but I think working within that to create something that's future proof, I think, is really important. So I think the other learn I'd say is, keep the patient in mind, keep all the system in mind, and keep that quadruple aim as your kind of guiding star. And I think if I'd had those things in my career, I may would be in a different place, maybe not, but they would have been really good things that a smarter me in the future would have passed down.
Yeah, I think that's a lot of wisdom, both personal wisdom and healthcare innovation wisdom. So that's really helpful. Thank you. So Tal, this has been great. Any other comments or things that you're watching that we should discuss? We've covered a lot of ground.
Yeah, I mean, look, I think COVID's sort of, still the big elephant in the room, right? I think the question, as a company that's kind of out there talking to payers and providers and, who are all quite head scattered in like, oh my God, it's COVID at my door. I think, I always think, I guess maybe it's a parting message, but yes, they're really important, and clearly people on the front line, my hat goes off to them. And, I've thought about even getting myself out there. We don't have that need here for more people on the front line, but if that need was there, I'd volunteer.
If you were in the US, you were in Houston, they'd be drafting you in.
Yeah, and look, and I'd be happy to do that. I think it's a really important role, and have that skill set, and being able to help people in their very fearful time is great. I think though, I think people can look at these these times as real threats, and they're existential threats. They're threats for putting food on the table, and clearly in Maslow's hierarchy, people who are in that space are going to be, pulled down to there. But, it happened to me the other day. I was walking and I bumped into an old friend who was telling me that her husband has a jewelry business that's, has 50 people working for them, and they're about to lose their business. And he sort of sat down and said, what do I do? Do I kind of, crouch and curl up into a ball and fetal position and, give this away? Because there's nothing he can do, right? The shops are closed. No one's buying jewelry when COVID's around. Or do they think differently and trying to, build their way out of this? And they went off and started set up an online COVID store, right, to sell hand sanitizer and masks, and trying to get, trying to help give people the things that they need. And so, I mean, when I left that conversation, part of me it gave me a bit of a slap and a wake up, and thought, there's a huge opportunity here with COVID. And I think we started talking about how the world's going to look differently. And my encouragement to entrepreneurs, to physicians, to anyone on the front line, to people out there sort of seeing this situation, this is also a time where I think Warren Buffett said this, right? When people get greedy, he gets scared. When people get scared, he gets greedy. And I think this isn't about sort of being a pariah, but it's about saying that in times of crisis, this is actually a point of rebuilding. Like, even though it feels, there's destruction around us and the world's falling apart, this is the time where the seeds can get planted for something really cool and big and meaningful and changing. And we can actually, not to sound Pollyannish, but we can recreate the world that we live in. We can rethink healthcare in a very new way. And so this is the point where, in the 2008 GFC, Uber and Airbnb came out of that, that disaster. And so I think, there's real opportunity here for people who start thinking innovatively and start really looking forward. And so I think amongst all the news stories, Vic, don't turn on the TV and spend 10 minutes in sort of innovation quiet space. I think we'll all come out of that if we each sort of turn off that news cycle and that sort of constant media feed of the fear today and think about the future. I think we can find something really cool. And we've pulled together a think tank to do just that here, where we've brought together some amazing health leaders to start recreating that future, just because it helps me start thinking a little bit clearly about what's next. It's where sort of that COVID community passport came out of, and some other ideas. So I think we all can see some opportunity, but I think it's about trying to find some space. When we have time's become maybe a little bit more available because there's less distraction. So I don't know if that's a parting word, but I think it's a really
I think that makes sense. That's probably a good parting word. I mean, I think the whole concept over the holidays of a storm coming through that we need to prepare for, but then it would open up kind of open space for new innovations to blossom. That's what I had in mind talking about the storm. The storm that actually arrived was not what I intended, but it's the same dynamic, right? There's going to be lots of change. There's lots of need for innovators to solve problems. There's huge problems out there. And so thinking creatively, I agree with you. Great companies, great leaders, great innovations are kind of formed in times like this. And taking action is the thing we need to do.
Yeah, and I guess back to your storm metaphor, there's going to be destruction around us. There's going to be cleanup that needs to happen. There's going to be opportunities to be able to do that effectively and humanely. And I think, I'm really hopeful. I think you've seen some really amazing humanity. You've seen some not such nice behavior with hoarding and other things. But I think on the whole, we will win, and we will get to the end of this, and we will create something that's really more meaningful in the future. And so thanks for the opportunity to sort of share that and
Well, Tal, thanks for sharing this. I think that was a great way to end it. And when you get out of lockdown and we can all fly again, we need to bring you to Nashville and talk about Scalamed and bring you to some place, doc's offices here.
Yeah, I love that. I mean, I love Nashville. It's a great town. It's a place I love coming back to. So can't wait.
Yeah. Okay. Stay safe there. I appreciate you doing this. Thanks.
Thanks so much, Vic. Thanks for the time.